Hi, my name's Mary Moss and today I'm giving a lecture on MSK imaging and arthritis. So the learning objectives: to describe the radiological findings in the common arthritides on X-ray and include description for particular osteoarthritis and erosive arthropathy. So an overview of the talk: what we're going to discuss is A, B, C, D, E of arthritis, and we're going to discuss a few specific scenarios including OA, rheumatoid, erosive OA, and to a lesser extent gout and CPPD. So when we approach arthritis on X-rays, it can be useful to try and remember all the features you're looking for to have some key. And A, B, C, D, E, S is a good way of approaching arthritises. A stands for articular involvement, and that's particularly erosions. B for bones, and that can either be productive change or decreased bone density. C for cartilage or joint space narrowing. D for distribution, and that can be within the hands or within the whole skeleton. E for extra findings, demographics, systemic symptoms. And S for soft tissue involvement, deformity, soft tissue swelling, calcification. So starting with A for articular, so erosions. The appearance of the erosions is very important to narrow down what the cause of the erosion and the erosive arthropathy is. We're going to talk about each of these in turn. But to start with, the normal. So this is a depiction or a cartoon of a normal joint. The yellow is the bone. The blue is the articular cartilage. This red is the joint capsule, and the pinky thing is the synovium, and you can see this bare area here where the edge of the articular cartilage stops, the capsule inserts, and there's a little bit of bone that doesn't have anything covering it. So the first one are erosions associated with RA. So these are marginal erosions occurring at that bare area. That's that area we described where your cartilage finishes, your capsule inserts, and there's a little bit of bone exposed between those. In rheumatoid arthritis, classically involves the MCPJ. In psoriatic arthritis, it can involve DIPJ. So here we have an example of rheumatoid arthritis with these marginal erosions. So here is your articular surface with your cartilage over the top. Your capsule will insert around here, and this is the marginal erosion. The next one we're going to talk about is associated with erosive OA, and this erosion occurs involving the subchondral bone plate. So the cartilage is destroyed, and then you get bony erosions underneath that subchondral plate. Here is an X-ray where you can see these erosions centrally involving the subchondral bone. And again, you can see here these central erosions occurring. Also with erosive OA, we get a gull wing appearance where you can see like a kid's drawing of a gull. And this is proliferative changes at the margins, central erosions, and you get this classic appearance. And again here, this gull wing type pattern, central erosions involving the subchondral bone plate. And the next one is psoriatic arthritis. So marginal erosions occur again at that bare area not covered with articular cartilage. These erosions can be so marked that they can whittle away the bone, and you get this narrowed or pointed bone said to look like a pencil. It doesn't really look anything like a pencil, but that's the characteristic description. The adjacent articular surface often has bone proliferation, and that forms a cup. So here we can see the cup formed at the base of the distal phalanx with this whittling away and this deformity or pencil shape of the proximal phalanx. The next one is gout. So the erosions with this one are classically juxta-articular or next to the joint. So you can see here the joint capsule coming in, and this is really just on the margin, and actually part of it can be extra-articular or near the joint, periarticular. Often occurs at the MTPJ. The erosions have overhanging margins, and may have a sclerotic margin at the edge, indicating slow growth. So here is a nice depiction of gout with these really sharp, punched out erosions, sclerotic margins, overhanging edges. So when you see joint space narrowing, it's important to ascertain whether this is from a degenerative process or an inflammatory process. And you're looking for classic X-ray features to support either one. With degenerative joint space narrowing, there's usually associated osteophytes, subchondral sclerosis, and usually there's an asymmetric distribution within the joint, as opposed to inflammatory arthritis causing the joint space narrowing. This is usually associated with bone erosions, osteopenia, soft tissue swelling, and there's usually more of a uniform or symmetric involvement in the joint space. A flow chart can be useful in going through these processes and coming up with your differential. So starting with the initial one, joint space narrowing. Are there inflammatory features? Is it got its symmetrical involvement of that joint space? Is there associated erosions, soft tissue swelling, juxtaarticular osteopenia? And that makes you think of an inflammatory cause. If you are seeing that, is it monoarticular or one joint, in which case infection needs consideration. If there's more than one joint involved, it's a polyarticular process. Really, you're thinking of rheumatoid arthritis or seronegative spondyloarthropathies, of which there's a number to consider. Back to that beginning, joint space narrowing. Has it got asymmetric involvement within that joint space? Are there associated osteophytes and sclerosis? That makes you think of a degenerative cause. Are the features and patient details typical for osteoarthritis? You can stop there. However, if it's got an unusual distribution, more severe, the age or demographics don't fit, think of atypical osteoarthritis, and in particular trauma, crystal deposition, neuropathic arthropathy, and haemophilia. D stands for distribution. You can look at the distribution within the hand and within the skeleton as a whole. And classically, different arthritises have different distributions within the hand. Osteoarthritis has a predilection for distal interphalangeal joints, thumb carpometacarpal joint, and the STT or scaphoid trapezium trapezoid articulation. Rheumatoid arthritis classically involves the carpus, MCPJ, and PIPJ. And psoriatic arthritis commonly involves both PIP and DIPJ. The distribution also involves the whole skeleton, and rheumatoid arthritis and osteoarthritis have a different distribution within the skeleton. You can see rheumatoid arthritis liking the cervical spine, osteoarthritis having the lumbar spine and SIJ, both involving the knee and hip, and different distribution within the hands and feet. E stands for extra findings, which really just encompasses everything non-radiological. Demographics, patient's age and sex, fever, systemic symptoms, skin lesions, other organ involvement, etc. S stands for soft tissue. So this includes deformity, swelling, and classically they call it sausage fingers, masses, and calcification. So you can see the top left picture has those beautiful punched out erosions that we've already described associated with gout. You can see this marked soft tissue swelling, again further soft tissue swelling here, causing splaying or separation of these toes. There's some amorphous calcification within this area, more dense calcification. Over here we have the dual energy CT. So the physics is beyond me, but gout shows up as green. And so you can see here extensive gouty tophi involving and corresponding to these soft tissues, also extending between the toes. Down here we have the deformity and the soft tissue changes and deformity associated with rheumatoid arthritis, the subluxation, ulnar deviation, etc. And of course, sausage fingers. So we're going to talk about a few different scenarios or arthritises. So the first one, osteoarthritis, is really what we consider degenerative joint disease, has also been described as wear and tear, and it's the most common form of arthritis in our community. The classic X-ray features are joint space narrowing, often asymmetric within that joint, subchondral sclerosis, usually occurring at the joint margins, osteophyte formation or bony spurs, and subchondral cysts or geodes. The joint space narrowing is usually asymmetric, and that's caused by destruction or loss of the articular cartilage. You can see this X-ray here. It has narrowing of the medial compartment, subchondral sclerosis. There's widening of that lateral compartment, and as a result we have that varus angulation of the knee. Subchondral sclerosis, that's white. You can see with the bone and these little tiny subchondral cysts occurring. Nice little osteophyte hanging off the edge. Subchondral cysts, when they're large, they're called geodes, and you can see this cyst involving the acetabular roof associated with this OA. Now, subchondral cysts are only seen in 1/3 of osteoarthritis, so when you don't see it, that doesn't mean it's not OA. Marginal osteophytes occur at the margins of the joints, and just because people like to get their name attached to things, Heberden's nodes occur at the DIPJ, Bouchard's nodes at the PIPJ. The distribution of osteoarthritis we've already talked about, classic distribution pattern. Now the causes, the one we all think of when we talk about osteoarthritis is a primary OA occurring in middle-aged females. There is an erosive or inflammatory subtype we'll talk about in more detail, but secondary OA is actually more common. A number of causes including trauma, so you can see this X-ray here with prior fractures involving distal femur, proximal tibia, proximal fibula, and they've got plate and screw fixation. The fracture's extended into the joint, which has become incongruent or it doesn't line up anymore, and that causes secondary osteoarthritis. Other causes of incongruent or irregular articular surfaces can predispose towards secondary OA, including osteonecrosis, inflammatory arthritis, CPPD, hemochromatosis, and acromegaly. So the A, B, C, D, E, and S of osteoarthritis. A, no erosions. B, no osteopenia, but productive changes, which are the osteophytes and subchondral sclerosis. C, non-uniform or asymmetric joint space narrowing, and you can have those subchondral cysts. D, we've already talked about the distribution. E, occasionally you can get subluxation or hallux valgus, and we've already talked about that genu varus deformity of the knee. And soft tissue, of course, the people who love to have their names after things, Heberden's and Bouchard's nodes. So next we're going to be talking about rheumatoid arthritis. This is a chronic autoimmune disease that affects the lining of synovial joints, gets resultant inflammation, and as a result painful deformity and disability. The classic X-ray findings are marginal erosions, soft tissue swelling, osteoporosis, and joint space narrowing. Marginal erosions occur at the margins of those joints. So we've talked about the articular cartilage protects the subchondral joint, and where you've got that bare area before when your capsule inserts, this is where these marginal erosions occur. And they're different from a subchondral cyst from OA, which occur deep to the articular surface. Soft tissue swelling, so a number of causes include joint effusion, soft tissue edema, and tenosynovitis, and this can result in sort of sausage digits. Osteoporosis is initially juxta-articular next to the joint, so that means that the bones are more lucent or black near the joints. Later it becomes generalized, involving all of the joints. Joint space narrowing in rheumatoid arthritis is classically symmetrical or concentric. destroying the articular cartilage in the medial and lateral compartment, much the same with this uniform joint space narrowing. And late we get this subluxation and deformity. So you can see here the subluxation and sometimes even dislocation occurring, ulnar deviation at the MCPJ, and extensive erosion within the carpus. The deformity associated with rheumatoid arthritis can have classic patterns, and there are specific descriptive terms that are used. Boutonniere deformity, the first one we're going to talk about, is where there is flexion of the proximal interphalangeal joint and hyperextension distal interphalangeal joint, causing a buttonhole deformity. The next one is a swan neck deformity, where there is a flexion deformity at the distal interphalangeal joint with hyperextension at the proximal interphalangeal joint. Ulnar deviation, we've already talked about, often occurs at the MCPJ. And opera glass or telescoping occurs, and this can cause this arthritis mutilans type appearance. The distribution, as we've already talked about, classic distribution involving MCPJ, PIPJ, the neck, hip, knee, shoulder, elbow. So, to summarize, the A, B, C, D, E, and S of rheumatoid arthritis. A, erosions are a typical feature. Classic appearance are marginal erosions. B, periarticular osteopenia is a classic thing. No bone production or proliferation, particularly in that active phase. C, uniform cartilage destruction, that uniform joint space narrowing. D, we've already talked about the distribution. E, extra findings. So the key thing is this is an autoimmune inflammatory process, and it can involve multiple other systems, including lungs, skin, eyes, heart. And soft tissue, fusiform swelling, that's sausage digit, nodes, lymph nodes, and deformity is a key factor occurring late in the disease process. Okay, so moving on, the next one we're going to talk about is erosive osteoarthritis. This is osteoarthritis with an inflammatory component. Classic X-ray features are joint space narrowing, subchondral erosions, bony proliferation, ankylosis can occur late, and the classic distribution DIPJ and PIPJ. So the central erosions and osteophytes cause a classic X-ray appearance. And so you get this biconcave articular surface. And so you can see here, causing a gull wing deformity. So this is that kid's depiction of a bird. And again, another picture of it. This articular erosions, subarticular erosions, proliferative changes at the margins, and this gull wing deformity. Distribution, as we've talked about, classically within the hands, DIPJ and PIPJ. So the A, B, C, D, E, and S of erosive OA, articular joint space narrowing. So what we see with osteoarthritis. B, bony sclerosis, productive changes, again what we see with osteoarthritis. The key thing is the C, subchondral central erosions occur, so that inflammatory component of the osteoarthritis. The distribution, PIPJ, DIPJ. Extra-articular findings, usually not many. Classic distribution, postmenopausal females. And because of that inflammatory process, you can get soft tissue swelling around the joint. So gout is defined as a defective metabolism of uric acid. As a result of the buildup of uric acid within the body, it deposits, and classically within the joints and juxta-articular, or the soft tissues around the joints. Clinically, the patient presents with episodes of acute pain. Classic X-ray features are juxta-articular erosion. So we've already talked about the classic location of the erosions just at the very margins of those joints. These erosions are usually punched out, well defined, sometimes have a sclerotic margin. The bone density is normal. Compare that to rheumatoid arthritis where it's not. and can have soft tissue calcification or tophi within the soft tissues. Location, we've talked about the feet is the place it likes the most, particularly at the metatarsophalangeal joint, first metatarsophalangeal joint, and the interphalangeal joint. It can also involve the hands, knees and elbows, and any joint. So the classic description of the erosions is called a rat bite erosion, or that punched out, well-defined erosion. Can often have sclerotic margins and this overhanging edge. So the A, B, C, D, E and S of gout. Articular, punched out erosions, usually more than 5 millimeters, spare the joint and have this overhanging edge. B, your bone mineralization is normal. Sometimes you can have chondrocalcinosis. C, joint effusion is present, but usually the joint space is preserved, so there's no destruction of that articular cartilage. D, the distribution, we've often said that it likes the toe, particularly the big toe. Extra findings, hyperuricemia, so that's increased uric acid levels within the blood, and usually affects males, but of course can affect anyone. Soft tissue, one of the key things are gouty tophi. This eccentric nodular soft tissue swelling due to crystal deposition around the joints. Often be hyperdense due to the crystals and can calcify. The next one we're going to talk about is the CPPD, or this is also called pseudo-gout. This is an inflammatory arthritis, and as opposed to gout, which is your uric acid crystal deposition, this is deposition of calcium pyrophosphates. And so these calcium pyrophosphate crystals accumulate in the joints and soft tissues, and clinically can sometimes have symptoms similar to gout. Classic X-ray features, so there's a combination of osteoarthritis, so that joint space narrowing, subchondral cyst formation, but also they have chondrocalcinosis. And as opposed to gout and rheumatoid arthritis, there are no erosions. The key factor is that you can get chondrocalcinosis, so that's calcification of the cartilage. And so you can see here on the x-ray that extensive calcification involving the articular cartilage, again here in the region of the TFCC and radiocarpal joint, extensive calcification. The distribution is different. So the key things, index and middle finger, MCPJ, at the carpometacarpal joints, and also involving hip, knee and ankle, pubic symphysis and the elbow. So this A, B, C, D, E and S, articulate, no erosions. Subchondral cyst formation, like in osteoarthritis. There can be joint space narrowing, again, like in osteoarthritis. The distribution we've said is typical. Key feature within the soft tissues is this chondrocalcinosis. Next one we're going to talk about is neuropathic arthropathy. And this is progressive joint degeneration and or destruction, and it occurs in patients with an abnormal pain sensation or proprioceptive response. So they don't get the feedback when they are from the joint when they are causing damage. So the classic X-ray changes for a Charcot or neuropathic arthropathy. Once again, radiologists love ways of remembering things. So 6 Ds. They stand for density, so increased density or sclerosis, destruction or bony destruction, debris or loose bodies within the joint, distension from a joint effusion, disorganization, and dislocation. So the A, B, C, D, E and S of neuropathic arthropathy. So the classic thing, no erosions, but the bone features are the main thing. So destruction, loose bodies, disorganization, increased density, deformity, dislocation, cartilage. So you can get joint space narrowing and ankylosis, so the degenerative type change. Distribution, often asymmetric, and it depends where there is actually no nerve response coming back. Extra findings: you may have vasculopathy, neuropathy, and the underlying cause of the neuropathy. Soft tissue swelling, deformity is a significant factor. So today we've talked about the approach to arthritis, and in particular when you're looking at an x-ray of arthritis, a way to approach it is the A, B, C, D, E and S, and that can help narrow down the differential. Couple of references. In particular, the Radiology Assistant for Arthritis is quite a lovely read. Beautiful pictures, nice, easy to understand text. Thank you for your time.